Good afternoon, everyone. I am Dr. Abarna from Kim's Cuddles Hospital. I am a pediatric immunologist and a rheumatologist. Today's session on Cuddles 1 is on Kawasaki disease. So in the today's session, we will talk about why are infants at high risk and why do they need intensification therapy. So we all know what Kawasaki disease is. Kawasaki disease is a medium vessel vasculitis and they have high prediction for coronary arteries. It usually affects children below 5 years of age. However, older children and adolescents also sometimes have symptoms of Kawasaki disease, and diagnosis has been made in older age group also. And Kawasaki disease is entirely a clinical diagnosis. There is no pathognomic laboratory test that says like, okay, you confirm the diagnosis of Kawasaki disease. So generally a clinician has to aware of this disease and how to pick up this disease earlier so that they can make a diagnosis of Kawasaki disease. Of all the vasculitis in childhood, now Kawasaki is the commonest cause of vasculitis, and it is also the commonest cause of acquired heart disease in children. Apart from the other vasculitis are Henningsolin purpura, Anga vasculitis, Takayasu arthritis, and polyarteritis nodosa. So, Kawasaki disease was originally first described by a Japanese clinician. He was working in a Red Cross hospital, and it was first described in 1961. So he compiled the first time he observed a child who had fever and red eyes, red lips, along with the unilateral lymphadenopathy and rashes. He found that he couldn't identify the cause for it, and he realized it is not an infective cause and something else is there. So, but he observed that after few days the child became afebrile. So he thought it is initially a self-limiting disease. So after in the couple of years, he noticed a lot of similar kids who are coming like that. So the first publication is on Japanese, but the first English published report is he compiled 50 cases and he reported. There's a first English report in that he has mentioned. Now it's not named as Kawasaki disease. It was called as mucocutaneous lymph node syndrome. That is most commonly seen in Japan. So he talked about it, and later, a few years later, they have noticed that this is not a self-limiting disease. The child who died and having the similar features, they have done an autopsy and they have found that there are coronary artery abnormalities. So they have found that this is not a self-limiting disease, and like they thought, and this has like a dangerous complications, which is coronary artery abnormalities. So they started to treat this disease with immunosuppressants. So initially they have given steroids for it, but later IVG came into the picture. So coming to Kawasaki disease per se, so like I said, it is now the commonest cause of acquired heart disease in children because we are using left and right antibiotics. So rheumatic heart disease or acute rheumatic fever is like slowly is fading out. So Kawasaki disease is a much more commonest cause of acquired heart disease. So of all the Asian countries, Japan has the highest number of Kawasaki disease, followed by Taiwan, South Korea, and India also has come into it. So the Asian population Kawasaki disease incidence is high compared to the other Western countries. Coming to the diagnostic criteria of Kawasaki disease, so this is 2017 diagnostic criteria by AHA, okay, American Heart Association. So in this, they have mentioned there should be fever for at least 5 days and presence of the 4 of the 5 principal clinical criteria. What are the 5 principal clinical criteria? One is the conjunctival injection, polymorphous rash, mucosal changes, cervical adenopathy, or acral changes. In the acral skin changes, in the acute phase, we can notice edema and erythema of hands and feet. In the convalescent stage, we see the periangle desquamation. And they have also mentioned this illness cannot be explained by any other known disease. So patient should have fever along with the 4 of the 5 principal clinical criteria. Okay, this was the 2017 AHA scientific statement criteria. So Kawasaki disease is you can't see all the 5 principal clinical feature at the same time. It's a constellation of symptoms. Whenever sometime a patient come to you at day 4 or day 5 of illness, But right now, when the patient present to you, the child may not have a red eye or a red lips. But in history, if you ask them, they say like the red eye was there in the day two, and it was there for only one day or 2 day, and it vanished on its own. So sometimes they say like there was a small swelling they have noticed. They have noticed swelling in the edema, swelling or edema on the hands and feet they have noticed. But when they presented to you, it was not there. So you should always ask the history whether this was there or not. Now it is improved. So even just in the history, if it was there, so it fulfills the clinical criteria. So it is a temporal sequence of clinical features. It may not occur at the time of presentation to your hospital, but it may present in history also. So you have to ask. So maybe if a child comes very early on a day two or day three of illness, it might have like only two feature. But if you observe the child by day five, it might have the complete features also. And anyway, like I said before, there is no laboratory test to prove this is Kawasaki disease. We have to observe the clinical findings. We have to ask history, and we have to make a clinical diagnosis. So coming to the new updated guidelines. So this is published in 2024. So this is a new AHA scientific statement on Kawasaki disease. So I want to emphasize on this. There is a new guideline that has come in 2024, and there are a lot of changes from the previous guidelines. So what does the new guidelines says? So previously in the 2017 guidelines, they have said like we can make the diagnosis of Kawasaki disease when the child have fever for 5 days. But the new guidelines have said if we can make the diagnosis even with 4 days of fever, if a patient have along with 4 or more principal clinical features. They have also mentioned one more statement. So that clinicians are encouraged to diagnose KD, Kawasaki disease, early to prevent the coronary artery dilatation and aneurysm. So the earlier you pick up Kawasaki disease, the better you treat it, and then the chances of coronary artery abnormalities, that dilatation or aneurysm, is less. So even you can diagnose Kawasaki disease from day 3 of life. It's not like you have to wait for 5 days and then you have to wait for all the principal clinical features. Many a time it can be incomplete Kawasaki disease. Many a time it can be atypical Kawasaki disease. Okay, so if you have an eye for it, you will be able to pick up earlier. So even the AHA guidelines says like you can diagnose Kawasaki disease as early as day 3 of fever. But now the one important thing that they've changed in the criteria itself, you don't need to wait for 5 days. Even 4 days, you can make a diagnosis of Kawasaki disease. So in the criteria, they have made a change, but they have also mentioned you can pick up as early as 3 days, and they're encouraging doctors to pick up early Kawasaki disease so that we can prevent coronary artery dilatation and aneurysm. Coming to the findings in Kawasaki disease, I will initially talk about the typical findings and the principal criteria. Then I will talk about the atypical findings in Kawasaki disease. So from day 0 to day 14, so these will be the main features, that is oromucosal redness. So they can have redness of lips, redness of buccal mucosa, and you can see crackling of lips also. The tongue will be red, like strawberry tongue, it will be there. The lymphadenopathy is generally a unilateral lymphadenopathy. Bilateral lymphadenopathies are, so the unilateral lymphadenopathy more than 1.5 centimeter, they say. And if you do an ultrasound, it looks like a cluster of grape appearance. So the first picture is like the red lips along with the cracking of lips. You can see the child is crying. So irritability is also one of the feature. One of the main feature of Kawasaki disease. Many a time you think, okay, it's a infant with fever and irritability, it is a meningitis. But if the child has a lot of other feature also, we can pick up Kawasaki disease. Okay. So this is strawberry tongue. So these two pictures depicts the unilateral cervical lymphadenopathy. Coming to the next picture, so this is conjunctival injection. So generally, it will be a bilateral conjunctival injection with the limbal sparing. So you can see there is a white rim that is the around the limbus, that is the limbal sparing. It doesn't involve the limbus, it affects the other areas. And this is a polymorphous rash that can be seen. The rash need not be such extensive. It can be a maculopapular rash. Apart from vesicular rash, the rash can be any type of rash also. So these pictures depicts the edema and erythema of hands. Many times we think, and this is edema and erythema of feet. So many times we think the child is edematous, or it sometimes if child has come from another hospital, we think like maybe IV cannula. That's why the limb swelling is there. So we have to ask the parents whether the limb swelling was there even before IV cannulation. Have they noticed this limb swelling in this child? So after that, from day 10 to day 20, once the fever subsides and the next phase, in the subacute phase, you can see few important findings. So you can see peeling. So here you can see the peeling, this picture. So you can see peeling of this finger in this picture. And there is a sheets of peeling in limbs in the last two pictures. So generally, it is a periungual peeling. So just after the nail, it will start to peel. So if even it doesn't, the peeling doesn't happen in the palms and soles. I mean, it does happen, but it will start from the periungual region. So in this picture, you can see Bue's lines, or you can see the transverse ridge that shows there was an inflammation and arrest in growth plate. After some point, once the inflammation subsided, again the nail plate started to grow. So that is the indication of these Bue's lines. So you can see as a transverse ridge. Sometimes other nail changes like onychomatosis can be there. They can have orange brown nails can be there in the later part. So this will be seen almost around at 3 to 4 weeks after the diagnosis of Kawasaki disease. There are few pathognomic signs of KD which are not included in the clinical criteria of AHA. So this is a 2-year-old boy, fever for 7 days, child had rash and an extensive perianal peeling. So the redness or rash in the perianal region and peeling in the perianal region is like one of the classical feature of Kawasaki disease, and it is more common seen in the young age group, especially in the infants. So this is another classical feature of Kawasaki disease, that is the BCG site reactivation. So this is a 8-month-old, fever for 7 days, and child had rash and BCG site reactivation. So why this is not included in AHA guidelines? So BCG is never commonly given in Western countries. So they have, this is like a very rare finding for them, because most of the kids there would not have received BCG. But this findings, the BCG site reactivation, has been included in the Japanese guidelines. So this is an important feature that they have noticed, and this which is site reactivation, that too it's more common in infant. They are also, these patients have higher risk of coronary artery abnormalities also. So this BCG site reactivation is however included in Japanese guidelines, but it is not in AHA guidelines. But it is a very important feature, especially in infants. So everybody has to check the BCG site in a patient in which you are suspecting KD, or in which you are not able to diagnose what is the reason for fever in those patients. So these two, perianal peeling and BCG site reactivation, are almost a pathognomic feature of Kawasaki disease. Coming to the laboratory diagnosis, we all know in hemogram, you can see the elevated TLC counts. So it is generally a neutrophilic predominance. And platelet counts, it initially, in case of high-risk patient, they can have thrombocytopenia. But commonly after a week of, on the second week of illness, you'll start noticing thrombocytosis. They'll have elevated inflammatory markers. They'll have like raised ESR and raised CRP. In urine, generally, it will be a pyuria, but when you do a culture, it is sterile. So sterile pyuria is a very common finding. And if you, and echocard is like a very important investigation. You can look for coronaries. One more important investigation is like you have to do pro-BNP, which can be elevated in patients with Kawasaki disease. So the main thing I want to emphasize is like the sterile pyuria. One more thing is like if a child is if an infant coming with irritability and rash, you are doubtful whether it's meningitis. So even if you do CSF in a patient with suspected Kawasaki disease, they'll have cells. They'll have aseptic meningitis and Kawasaki disease. So it confuses the picture. Many times you think it is meningitis, but they can have other features of Kawasaki disease. So you better, if you are having doubts, you better do echocardiography and pro-BNP levels also in those patients. So one more thing is like, even if you give IVIG, if you do lumbar puncture after that is CSF examination, they can still have elevated counts. So that also confuses the picture, and it also looks like aseptic meningitis. So these are the few things that you have to know. And one more laboratory feature that you can do is like you can do the ultrasound abdomen, so we can see gallbladder hydrops, so which is also a telltale sign of Kawasaki disease, apart from the ones that I have uh, put in this picture. Sorry, in this slide. So we should always take with a pinch of salt when a child comes with a sterile pyorrhea. So coming to the biomarkers of Kawasaki disease, we don't have like a specific biomarkers or a genetics that is correlating to Kawasaki disease till now. But yes, pro BNP, there is pro brain natriuretic peptide is like one of the important features that has been associated with Kawasaki disease. A cutoff level of 1025 picogram per ml of pro BNP level in acute phase of KD had a 88% sensitivity and 96% specificity. So pro BNP is mandatory. When you have doubts, you can, if it's high, you can think more towards Kawasaki disease, and you can do a echo also on those patients. Coming to the topic per se, that is Kawasaki disease in infant. Why I have chosen this topic? Why it is important to identify Kawasaki disease in infant? Why it is like a separate topic. So in the subsequent slide, you'll get to know why it is very important thing that Kawasaki disease in infant is like a special as a class I am taking today. Okay, so KD in less than 1 year is always difficult to diagnose because many a times the Kawasaki they won't have a complete feature. So many a time it will be an incomplete Kawasaki disease. They don't have like a complete forms, and these subgroup of patients are like very high risk of developing coronary artery abnormalities. And many times they can have atypical picture, and so if they come a child with irritability, fever, and some rash or some redness, and we'll always think about meningitis, and KD is comes very lower down in the picture. So and if you delay the diagnosis of KD in these patients, there is a high chance these patients develop coronary artery abnormalities. So I am discussing few case scenarios. So this is a 2-month-old girl. She has presented with fever for 15 days. So you can see the child has rash. So the rash is like there are a lot of different patterns of rash you can observe in this child. So child had maculopapular erythematous rash, child has cheilitis, child have some plaques with the hyperkeratotic papules, child is very irritable, child has perianal region rash and some peeling in the perianal region also. Apart from the child also had rapid breathing. The child had tachycardia and rapid breathing. So of course, sepsis workup was done. Cultures was sterile. Child was started on antibiotics. Investigation, there was thrombocytopenia and anemia. So this is one more finding we can see. Child started to peel because like child has come after 2 weeks of the illness. So we have done echo for this child. So you can see the child has LAD aneurysm. You can see 2 aneurysms in the LAD. So this is LMCA and this is LAD. You can see there are 2 aneurysms in the LAD. So this child was treated with IVIG. So in a child who was already having coronary abnormalities, this child has high risk features like very in infantile age of presentation. Child had thrombocytopenia. So apart from IVIG, child was given other drugs also. Child was given pulse steroids followed by oral steroids. Child was given cyclosporin. Because of a large or giant aneurysm, the child was given enoxaparin and aspirin also. Next case. So this is a 7-month-old boy. Child presented with fever, maculopapular rash, redness of eyes, swelling around the neck, and child was initially treated outside with oral antibiotics and antipyretics. But in the second week also, child continued to have a fever, so child was admitted. From the oral antimicrobials, it was changed to IV antimicrobials. In the third week, the fever persisted. The child started to have generalized swelling, respiratory distress, and taken to another hospital. By the time the child developed pericardial effusion, child had like moderate mitral regurgitation, child required mechanical ventilation, vasoactive support. So in this time, the treating doctor has found that the child had like few features of Kawasaki. This may be a complication of Kawasaki. This is having cardiac manifestation in the form of KD shock syndrome, and also child has pericardial effusion and mitral regurgitation, which are the other cardiac findings apart from the coronary abnormalities. So child was given IVAG and child was discharged on oral steroids. So at follow-up at 10th week, this child, we have done a 2D echo for this child, and it's shown a large giant aneurysm in the left anterior descending with a thrombus. Sorry. So this is the echocardiography of the child. So this is an aorta, this is LMCA. From this, you can see this large left anterior descending aneurysm. In this, you can see the white thing that is a thrombus. So this entire thing is an aneurysm in which there's such a big thrombus this child had. So this is the same thing. So this is the thrombus in the aneurysm. So you can see this child, the child that I have described, the main issues. Child is a 7-month-old boy. So being a male is a risk factor. The age less than 1 year is a risk factor. So child did not. We have not picked up early in the child. The diagnosis was late, and the child was not adequately treated with immunosuppressant. So when we did a follow-up echo at 10th week, this child had such a giant aneurysm along with a thrombus. So this child's LMCA was like +3 Z score, left anterior descending. This is main coronary artery. So left anterior descending was like they have giant aneurysm that is like 14.9 mm and Z scores are around almost 47. This child had left circumflex aneurysm also that is almost 11 Z score, and its LV function was normal. So I will talk about why this diagnosis of KD in infants is difficult, because it's almost always incomplete, and generally they'll have few unusual features or atypical features that makes the diagnosis very difficult in these cases. So this is age 2004. There's a very old guidelines, and what they have talked about KD in infants. So they have told in a child with less than 6-month-old with fever for more than 7 days without any underlying explanation or cause, and should undergo laboratory testing. And if any evidence of systemic inflammation is found, echocardiogram should be done, even if the infant does not have any clinical criteria. So this 2004 guidelines initially stressed the importance of echocardiograph. Now, any infant for fever for 7 days, you don't know the cause. You are giving antibiotics for such a long time, but child continued to have fever. So you have to do an echo to look for a coronary artery abnormality. So this first guidelines in 2004, they have emphasized the importance of echocardiogram in KD in febrile infant. In the 2017 AHA guidelines, they have told infant more than 6-month-old if they have prolonged fever and irritability. So this is one of the criteria they have told. In that patient, you can suspect KD. The second one is like the prolonged fever with unexplained aseptic meningitis, prolonged fever with unexplained culture negative shock, prolonged fever and a cervical lymphadenopathy unresponsive to antibiotic therapy, prolonged fever and a retropharyngeal or a parapharyngeal unresponsive to antibiotic therapy. So these are the things in those patients you can suspect Kawasaki disease. That's what they have mentioned. Coming to the 2024 updated guidelines, however, the criteria for incomplete KD was not changed. So the main thing that they have mentioned as a risk factor is like when the child have RCA or LAD, Z scores more than 2.5, or any child with less than 6 months are a high risk, and then they should go for a primary intensification. So any Kawasaki disease patient less than 6 months you are diagnosing, they apart from IVAG, you have to give an additional therapy. That is the intensification. You don't wait for the coronary artery abnormality to occur. You intensify even before the coronary artery abnormalities occur. So that is the one that is that means intensification of primary therapy. So this does intensification of primary therapy does not mean you have to wait for the resistance or you have to wait for the coronary artery abnormality to occur. You do it when a child comes with a 6 month, less than 6 month old, you are making a diagnosis of KD. Apart from IVIG, you have to do one more. You have to give another drug. So why it is important and stressing? Because there's many a time it's always incomplete, and then the diagnosis criteria did not give much emphasis for the diagnosis of KD in infant less than 6 months. So these are the few publications from Japan. So we all know like Japan is the main place where research of Kawasaki disease is happening, where the incidence of Kawasaki disease is high. So these are the few main people who are involved in the research of Kawasaki disease. They have reported patients or infants without fever, but they have features of Kawasaki disease. Like they can have other principal criteria, but not the fever. So they can have rash, redness of eyes, oral mucosal thing, but without fever. So even those patients can be diagnosed with Kawasaki disease. So these are the few reports of a patient in which they have done a coronary artery abnormal. They have found coronary artery abnormalities in echocardiography, even though the patient presented without fever. So this is another case report in which they have mentioned like a 4-month-old but fever for less than 3 days, but they didn't follow AH algorithm. But this child developed coronary artery abnormality by day 10 of illness. So this is Japanese guidelines for classification of coronary for classification criteria of Kawasaki disease. So in this, like I said, one important difference is like BCG inoculation that is not there in Kawasaki disease. One more thing is like if you see AHA guidelines, they say like fever plus 4 of the 5 principal criteria. So it was always fever should be there and 4 of the rest of the 5 criteria. So in this Japanese guidelines, they have mentioned fever as also one of the criteria, and the other things like red eyes or like bilateral bulbar conjunctival illness, oromucosal changes, rash, extremity changes, lymphadenopathy, all of them as like a criteria only. So you have to classify them as a complete KD if they have 6 or 5 of these features. So sometimes they can have illness even without fever. So even in that also they can say it's a, if they fulfill the other 5 criteria, it is called complete Kawasaki disease according to the Japanese guidelines. So for an incomplete Kawasaki disease, so they have mentioned if even the criteria are less and you are finding a coronary artery abnormality, if you have high suspicion, you can still make a diagnosis of Kawasaki disease. So this is a Japanese diagnostic guidelines, even though it's not mentioned in Nelson or anything, but it is very important because this disease, Kawasaki disease, is more common in the Asian population and it's more commonly seen in Japan, and it is a leading country for evaluating Kawasaki disease. So we should take their inputs also in diagnosing this disease. So coming to the challenges that faced during echocardiogram in an infant. So we all know infants, they'll be like crying more. Generally, their heart rate will be high, so they'll have tachycardia. They'll be more irritable, and even if you're doing a lot, if you're trying to console you, if you're sedating the child has a narrow coastal window also, and it is very difficult to visualize the distal segments of the arteries. And it is very difficult to visualize coronary arteries in an infant. So we always need an expert pediatric echocardiography focused on coronary arteries in patients in whom we are suspecting Kawasaki disease. Coming to the CAA incidence in infant. So between aged 6 to 12 months, its incidence is almost 40%. In less than 6 months, the incidence it's nearly 68%. So it is always important to look for coronary artery abnormalities and then treat before this coronary artery happens in Kawasaki disease. So this is a study from USA by Adriana Tremolet. So you can see the child less than 6 months and more than 6 months, they have compared. There is a significant difference that incomplete KD occurrences more in children less than 6 months, And aneurysm and giant aneurysm, they are also like insignificantly high in less than 6 months of age group. So this is a subgroup analysis from Jane C. Burns group. So they have classified Kawasaki disease patient into 4 different subgroups. So they have done a cluster analysis. So one is a liver subgroup, one is like a band subgroup, one is a nodal subgroup, another is a young subgroup. So this young subgroup is the one that we are talking about today. So what is the importance of this subgroup? So in this subgroup, they have noticed that the incidence of cervical lymphadenopathy is low. In the laboratory tests, you see a high platelet count, high percentage of lymphocytes, lower percentage of neutrophils and band forms. So because generally we'll say like TLC will be high and neutrophils will be high, but in this subgroup of patient, they have noticed that the patient have higher percentage of lymphocytes and lower percentage of neutrophils and band forms, and they may not have as high CRP as like the other groups. So sometimes they can have like a not so high elevated CRP also. But this subgroup has this one important thing. They have high risk of coronary artery aneurysm. So of all the 4 groups, so this young subgroup, that is like the infantile age of presentation, they have a high risk of coronary artery abnormalities. And the other risk factors like IVIG resistance or KD shock syndrome is comparatively less in this group. So the KD shock syndrome is more high in the patients who have high band neutrophils, and the IVIG resistance is more highly seen in patients who are in the liver subgroup. So the liver subgroup was the patient who has like high transaminases, high GGT values, and high bilirubins. So those patients have increased risk of IVIG resistance. So coming to the infants and CAAs, the factors that are associated with coronary artery abnormalities include high percentage of neutrophils, increased peak platelet count, reduced hemoglobin within the 4 to 6 days during the acute phase of illness. So these are one of the subgroup of patient who requires high VAG. So there are like multiple studies which shows different risk factors. So I'm gonna talk about which are the main risk factors in those subgroups will require a primary intensification. So we in India we don't have a very standardized risk factors or a scoring system to classify them as like a high risk and then to give a primary intensification. However, in Japan we have lot of scores. Sun-risk score is there, Sano score, Igama score, Kobayashi score. So there are a lot of scoring system is there to look for risk factors. So I will in the subsequent slide I will talk about the main risk factors which require a primary intensification. So the main risk factors are the age less than 1 year, male sex, male gender is like a risk factors, prolonged duration of fever, so they can have a high risk of coronary artery abnormalities, delayed initiation of IVIG. So the earlier you detect it, so you can prevent the coronary artery abnormalities. So if you delay the IVIG after 10th day of illness, in the follow-up, there are high chances that they can develop coronary artery abnormalities. Of course, IVIG resistance is an important risk factor, and if you do echo at the time of presentation and they have coronary risk scores more than 2.5 at baseline, that itself is a risk factor for further progression of coronary artery abnormalities. Coming to the CAAs and IVIG resistant, patients with Kobayashi score of more than 5 are prone for IVIG resistance, and the risk of CAA increases significantly with IVIG resistance. So, incidence of CAA is high among high amongst the IVIG resistant KD, irrespective of IVIG resistant diagnostic criteria. Okay, so these are the multiple scoring system given by different countries. So the common thing that you can see is like a age. So many in few countries they say like less than 6 months, but many places they say like less than 1 year. Also, you should take as a risk factors. That is the infantile age group you have to take as a risk factor. The male sex is a risk factor. The delay in diagnosis, the duration of fever, so more than 10 days is a risk factor. So IVIG day of infusion. So if you give the IVIG infusion very late, it is a risk factor. The child has anemia, child has thrombocytosis at presentation. Apart from that, IVIG resistance in case of CA at diagnosis, sometimes even incomplete KD has high risk is a risk factor for coronary artery abnormalities. There are few other risk factors that has been associated with coronary artery abnormalities. So one rare presentation is macrophage activation syndrome. So few KD patients can also have macrophage activation syndrome. So we generally say like hepatosplenomegaly is not commonly seen in Kawasaki disease. But if patient have features of Kawasaki disease along with hepatosplenomegaly and cytopenias, you have to suspect macrophage activation syndrome. And these patients have high risk of development of coronary artery abnormality. So these patients require upfront intensive therapy. So coming to atypical Kawasaki disease. So what are atypical Kawasaki disease? So apart from the classical features, these patients can have neurological manifestation. They can have pulmonary manifestation. They can have sometimes they can develop gangrene. Sometimes they have abdominal presentation. So these are the atypical features of Kawasaki disease. This why it increases the risk, because if they have any atypical presentation, it delays the diagnosis of Kawasaki disease. So the more the delays, the higher the risk of coronary artery abnormalities. Apart from that, some of them can have a systemic artery aneurysms. So what do you mean by systemic artery aneurysm? We generally say like KD generally affects coronary artery abnormalities, but Kawasaki disease can also affect systemic arteries, especially axillary arteries like the commonest. It can be followed by any other systemic arteries also. We have seen patients involving abdominal aortas and branches of abdominal aortas also. So coming to the primary intensification treatment, so we have to hit hard if a child is an infantile age group. Even older children, like more than 5 years, are also at high risk of development of coronary artery abnormalities. So even in those cases, you have to hit hard. If they have atypical presentation, if they have severe form of Kawasaki disease, either they have shock, either they can have macrophage activation syndrome. So in those patients, you have to intensify the treatment. And of course, if they have resistance, if you can use the scoring system. So you can use either of the scoring system like Kobayashi or Sano or Sun scoring system. If the patient have CAA at presentation, if the fever duration is of longer duration, so you have to hit hard even during that time. So the ultimate goal of therapy is like to eliminate the risk of CA. So we generally say like if you don't give IVAG, the risk of developing CA is 25%, and if you give IVAG, the risk comes down to 5%. So and the patients with infants and all this high risk group, the CA is almost like 40 to 50%. So you have to come down the risk. That's why we always give more drugs. That is the intensified therapy we give. Why is it important? So this coronary artery abnormalities that it is developing now, so this can go into stenosis, and these patients, they can have very early atherosclerotic event. Like if generally when you say like around 60 years, if a patient is developing atherosclerosis, these patients can have like a very young age group only, they can develop myocardial infarction and atherosclerotic complications. So this is the evolution of treatment in Kawasaki disease. So like I said, initially aspirin and prednisolone was given. In 1983, they first used intravenous immunoglobulin, and they found that this reduces the risk of coronary artery abnormalities significantly. So IVIG became the standard of care since then. So they made IVIG intravenous dose of 2 gram per kg as a standard of treatment from 1991. So following which there are few studies come. So RAISE trial. So RAISE trial is for the intravenous immunoglobulin along with prednisolone for patients who are at high risk. The steroid usage started around 2012. From 2014, infliximab as a primary intensification therapy has been introduced. And 2019, cyclosporin is also involved in the treatment of Kawasaki disease. So the trial was Kaika trial. Nowadays, the recent publication is on Anakindra on Kawasaki disease. So the trial called Kawakindra. So in case of refractory cases, Anakindra has a role. So like I said before, so generally KD overall without treatment, the risk of coronary artery abnormality is 25%. So you give IVIG, it is reduces to 5%. So in case of high risk patient, if you give On top of, you give other intensified therapy like infliximab, cyclosporin, or steroids, reduces to nearly 1%. But the thing is, like, we don't have like a documented data just in infants how much percentage it is reducing. We are hopeful that it reduces almost to like 1 to 5%, but it is important to treat them earlier, because like uh, the risk of coronary arteries or abnormality in infants is almost 50%. So this is AH 2024 guidelines. So these are the drugs they have mentioned in the intensification therapy. So they have mentioned steroids, prednisone and methylprednisolone. They have mentioned infliximab and etanercept. So they have also mentioned about cyclosporin and anakinra for cases, the refractory cases, and also for the resistant patients, you can use it. So you make a diagnosis of KD, but you have to look for these important findings, whether there's their age group. So the child is infant, child is male, sex, the duration of fever, if it's more than 10 days, child had persistent elevated inflammatory markers, whether IVIG resistant is there or not, coronary artery abnormality at the time of presentation, if the child have any complication like macrophage activation syndrome or KD shock syndrome. So you have to intensify the treatment. So upfront, you give IVIG and any of the drugs. Sometimes in severe forms, we have used all four agents also. So the agents we can use is infliximab, steroids, cyclosporin, or anakinra. If these features are not present, generally we go for IVIG alone. So you have to look for the these risk factors at presentation, and then you can intensify the treatment at presentation rather than waiting for the complications to occur. So in the treatments, in the subgroup of infants, so I will just talk about one case and how we manage this infant. So this child had 6 weeks vaccination. 4 days later, the vaccination, child developed high-grade fever, generalized maculopapular rash, conjunctival injections, and oromucosal redness. So this local practitioner treated this child with oral antibiotics. Child became afebrile. After 10 days of the illness, the child started to have skin peeling. Child started to have one more rash. That is, child started to have a well-defined erythematous facial rash, and child also started to develop gangrene. So we have, when the child presented to us, we have looked back at the illness. There was a feature of Kawasaki disease, so we have done echo in this child. So you can see the child. This is LMCA, so this is LAD. Child had like left anterior descending aneurysm. So this is LCX. So LCX is like the very small artery, generally not seen in echocardiography, but you can see this child had like a huge LCX aneurysm. That is the left circumflex artery. So this was almost plus 20 Z score. So apart from that, the child had aneurysm in all the arteries also. So child had LMCA, LAD, RCA aneurysm, and child had in the LCX, child had like giant aneurysm. Even in the LAD, aneurysm was giant. So we have to intensify, because even this case, it was incomplete, and this case have severe. Apart from the coronary artery aneurysm, this child had gangrene also at presentation, and this child had like a giant aneurysm involving almost all the arteries. So this is AH 2024 guidelines. So what AH 2024 guidelines says? So if you have any high risk, so intensification of therapy you have to do, and then you have to do a repeat echocardiography, and then you have to look for the evolution of coronary arteries in the follow-up also. If they have resistance, you have to intensify the treatment. If the child is responding only with IVIG and doesn't have any high risk factor, can just give IVIG and aspirin and then discharge the child, and then we should not give any live vaccine for the next 11 months. So this is the scoring system that has been given in AHA. So previously the the scores and the risk factors that I have mentioned is from India. There are studies from PJ Chandigarh. So this is scoring system that AHA has mentioned. So that is age less than 6 months, Asian race, if they have coronary artery abnormalities, or CRP more than 13. That any scores system of more than or equal to 3 months, you have to intensify the treatment. But in Japan, they say like less than 12 months, even a child less than 12 months, you have to give intensify the treatment. So they have said in case of normal child, you have to give IVIG 2 gram per kg over 8 to 12 hours. This is also one of the important thing. You should give IVIG within 8 to 12 hours. Not we should not give for a longer duration of time. And we can give low dose aspirin, and aspirin should be continued for 6 weeks. So the drugs that has been used for intensification therapy is infliximab, steroid, cyclosporin, second dose of IVIG, and anakinra. So the case that I have mentioned was come with the toe gangrene and the giant aneurysm. So this child we have managed with IG 2 gram per kg, and we have started the child on cyclosporin, but child started to develop other abnormalities, like child started to develop shock also. So we have started the child on all the inotropic support. We have started on HFNC. So because of the continued illness and giant aneurysm, we have given infliximab for the patient. So even with that, child continued to have myocarditis when after giving 4 different drugs. That is like you can see IVIG we have given, infliximab we started the child on cyclosporin. We were giving methylprednisolone pulse, but child continued to have myocarditis. That is like child had ST changes in ECGs, and tachycardia was persistent. So we have given one more dose of IVIG. So after that, the child improved. So in the meantime, we have given inotropic support. We have given HFNC also. So we have started the child on LMWH because giant aneurysm is there. So it is an indication for anticoagulants. So we have given LNWH. Along with that, this child also had gangrene. So we have given LNWH and maintained the cell. Because of the myocarditis and everything, we have started the child of propranolol and atorvastatin also, because all this child having aneurysms and giant aneurysm, they are high risk for atherosclerosis. So we have to give statins also in those patients. So to summarize, KD in infants tend to be like severe, and the few cases I have depicted also, most of them have like giant aneurysms. So I'm still trying to emphasize the need for primary intensification in infants. And these patients have high risk of coronary artery abnormalities. And then we can use drugs like infliximab, steroids, cyclosporin, and you can use a second dose of IVIG or anakinra. So infliximab will give around 5 to 10 mg per kg. It is like we will give over 4 hours, and cyclosporin 3 to 5 mg per kg we can give, and steroids different dosage has been mentioned the different textbooks, and it all depends upon the place in which you are working. So you can follow AHI guidelines for that. But it is important, you should know what are the drugs you have to give and why you should give, and then you should not wait for the complication or a coronary artery abnormality to occur. So you have to intensify even before a child develops coronary artery abnormality. So that is the goal. So I thank my parent unit in which I have undergone training, that is PJ Chandigarh, and I thank Kim's Cuddles for this opportunity. Thank you so much.